So I welcome everyone for the ICOG HORMONY web series. We have been conducting a lot of these topics over the past few months. It is organized by FOGSI in association with Endocrinology Committee of FOGSI and ICOG. I would like to first invite Dr. Parag Biniwale, the chairperson of ICOG 2025, to speak a few words and welcome everybody.
Uh, Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to welcome all the delegates and faculty for today's episode of Harmony. Let me appreciate the efforts put in by the Endocrinology Committee of FOGSI, led by Dr. Chaitanya Ganpule, Professor Vaishali Nayak, who's also convener of this program, ably assisted by Dr. Mansi Naralkar, Dr. Mansi Sharma, Dr. Madhu, who are doing excellent work for last 9 months. I welcome today's faculty, Dr. Garima Kachwa, who's a professor at the very prestigious AIMS Delhi. Garima, pleasure to have you here. And of course, our two eminent chairpersons, Dr. Kanchan Prasad and Dr. Kiran Bhai, who are the teachers in medical colleges. I'm looking forward to this interesting session. I'm sure Garima will give us a great insight into secondary amenorrhea, which is a common problem faced by us clinicians. My best wishes for the program, that I'm sure the quiz also will generate a lot of interest in the mind of the youngsters. So happy learning, everyone. Thank you very much.
Thank you so much, sir. I would now like to welcome our two chairpersons for today's session. Dr. Kanchan Prasad, she is the professor at TMMC and RC Moradabad and has, of course, a lot of awards to her credits. And she has, so she's a published author in many journals as well. As well as Dr. Kiranmai Devineni. She is the professor OBG at GMC Vanapati in Telangana. And she is also the chairperson to FOGSI Say No to Violence Against Women Committee from 2022 to 25. We welcome you, madam. And without further ado, I would like to hand over to our speaker for today, Dr. Garima Kachava, as Parag sir rightly mentioned. She is the professor in AIMS in Delhi, and she has several awards, several publications to her credit. We welcome you, madam, and I hand over to you now.
So can we display madam's slide and chairpersons to introduce?
Thank you, ma'am. Can I have the CV of Garima Kachava, ma'am? So today, Garima ma'am is going to talk about very commonly encountered problem in OPD, that is secondary amenorrhea. And we all know Garima ma'am. She is a professor in Department of Obs and Gynae, AIMS, New Delhi. And she has received many 37 awards, including many prestigious awards like FOGSI Korean Award and Silver Medal at AIMS Research Day, PhD candidate. So, ma'am has 103 scientific publications in various index journals, and ma'am is principal investigator in research project. The in seven research project, ma'am has authored around 30 chapters in 10 books, and also the her area of interest is high-risk pregnancy, gynecological endoscopy, and reproductive endocrinology. So, ma'am, we welcome you for this important talk.
Thank you so much, madam, for inviting me, and thank you so much for the introduction. So, I am sharing this topic, slides. So, am I visible? Are the slides visible there?
Yes, ma'am.
Okay. So, today I was asked to speak about secondary amenorrhea. And secondary amenorrhea is very common in our day-to-day practice. But what we need to now understand is the approach to secondary amenorrhea, because it can cause because of various reasons from head to toe. It can be effect of various systemic disorders also. So what is secondary amenorrhea? Secondary amenorrhea is the cessation of menses in a previously menstruating individual. This is very important to understand that a previously menstruating individual, whether the cycles are regular or whether they are delayed, it doesn't matter. But if the menses had ever come, then absence of menses in such a woman is known as secondary amenorrhea. And for a duration of previous 3 cycles in women with regular cycles. So how do we say how much amenorrhea should be there before we label a patient or we call that a secondary amenorrhea? So the duration of amenorrhea should be equivalent to previous 3 menstrual cycles for that women with regular cycles, or for a duration of more than 6 months in women with irregular cycles. So for all practical purposes, the woman is having amenorrhea for 6 months, she should be evaluated for secondary amenorrhea. Now, secondary amenorrhea is not a diagnosis in itself. It is a sign that requires careful assessment to determine the underlying cause, which can be varied. So let us first understand how menses occur. So we all know, let's go into physiology. We all know about hypothalamo-pituitary-ovarian axis. So this axis should be intact for normal menses to occur. Any problem in this axis anywhere may lead to disruption of menses. So we all know that in the central nervous system, there is hypothalamus, which generates the GnRH analogs, which act on gonadotropin releasing hormone, which act on pituitary, the anterior pituitary, where the anterior pituitary is stimulated to secrete gonadotropins. The gonadotropins are FSH and LH. These FSH and LH, they go and they act on the ovary, that stimulates the ovary for follicle maturation, and ovulation happens, which produces the whole process of this ovarian cycle produces estrogen initially, and then estrogen plus progesterone, which act on the uterus, and menses happen. So this is very important. This is the intact HPO axis. It has 4 components: hypothalamus, pituitary, ovary, and uterus. So problem anywhere may cause secondary amenorrhea. So after understanding the HPO axis, we now know that what can be the causes of amenorrhea. So the amenorrhea can be caused by disorders of hypothalamus or central nervous system affecting the hypothalamus, which may cause decrease in the secretion of gonadotropin releasing hormone. Then this will not be able to activate the HPO axis at all. Or can be because of disorders of anterior pituitary. Hypothalamus is acting perfectly, but the pituitary is not able to respond to the GnRH, the stimulation. So it may be because of presence of infection, tumors, empty cilia syndrome, or whatever. So the disorders of anterior pituitary can cause secondary amenorrhea. Now, or the disorders of ovary. So this is something that we are well versed with, and we know that anything happens to the ovarian follicles, if there is depletion of ovarian follicles because of various reasons, or the ovary is not functioning properly, it may cause secondary amenorrhea. And in the end, the target organ. Uterus is the target organ. So if there is any infection or any etiology that is causing damage to the end organ, will not be able to produce menstruation. So this may lead to secondary amenorrhea. So any causes over this HPO axis may cause secondary amenorrhea. And our aim through this lecture will be to differentiate between the various causes and to see and have an approach that how we can differentiate. So now, how can these various organs can be affected? Now, the most common is physiological. Everything is perfect. HPO axis is also perfect, but if any reproductive age woman is presenting with secondary amenorrhea, we know that the most common physiological reason for this is pregnancy. So pregnancy should be ruled out in any women of reproductive age group presenting with pregnancy. Presenting with secondary amenorrhea. Now, this can usually happen we should also do this, rule out pregnancy at the extremes of age also, where we feel that pregnancy may be less likely to happen But if we are evaluating for secondary amenorrhea, then we should rule out pregnancy. Then second most common cause is breastfeeding, which we normally cause lactational amenorrhea. So the women may come with, I am not having menses, but when we find out, then we know that she has recently delivered and she is lactating. Use of various contraception devices may cause amenorrhea. We know there are various contraceptive devices. By virtue of their mechanism, they cause amenorrhea. LNG IUS is the most common of it. So these things may cause secondary amenorrhea. Then we should always take a history of any drug use, which may be various forms of hormone preparations that the patient is taking. Then secondary is perimenopause. Perimenopause is age group where the women may start having delayed menses or infrequent menses. So she may have menses in 4 months, 6 months. So this may also be the cause of secondary amenorrhea. So these are the physiological causes which we are able to, find out or confirm by various history also. Then there may be hypothalamo-pituitary causes. Now, these are the causes which indirectly which affect the HPO axis. So, hypothalamus is affected if there is severe eating disorders. Either there is bulimia, which is excessive eating disorders, or there is, anorexia, where they are rapid weight loss because the patient does not feel like eating. She has a negative body image and she wants to become very thin, or because she is an athlete. So she does a lot of exercise and she has to maintain her weight between a bracket to suit her athletic requirement. So these are the women which pose a lot of stress on hypothalamus, and they may, because of their critical mass is very low, so they may have their GnRH secretion is not impulsive, and the frequency and the amplitude is not up to the mark. So they may have secondary amenorrhea because the GnRH deficiency or hypothalamic causes. So there will be a relative gonadotropin stimulating deficiency, or either if there is involvement of the central nervous system in severe infections, which may lead to problems in the hypothalamus or pituitary. Then there may be certain chronic disorders, autoimmune disorders, or sarcoidosis, which are infiltrative diseases. So they may also cause difficulty, or they may cause problems in the hypothalamo or pituitary, wherein the gonadotropins are not secreted. Or else there may be empty sella syndrome, which we will be discussing. Then there may be certain tumors of the central nervous system. Either they are having pressure effects on the hypothalamus, or the tumors of the pituitary like prolactinoma, or may cause secondary amenorrhea. Or then there may be the patient may have undergone certain surgery, trauma, head injury, or radiation because of tumor anywhere in the body may cause secondary amenorrhea. Now, what can be the ovarian causes? Now, gonadal dysgenesis is a cause for primary amenorrhea. But if the patient is having Turner variant or a mosaic, then these patients may have menses, but there will be accelerated loss of the follicles, which may lead to secondary amenorrhea, infertility, or premature ovarian failure, or POI. So we should keep in mind that the gonads may have some chromosomal abnormalities which may cause POI, then autoimmune destruction. And a very common cause of secondary amenorrhea is PCOS, POI, which we are well aware of, or there may be various estrogen or androgen secreting tumors in the ovary or somewhere else. Then the uterine causes. Uterine causes, infections is the most common cause which may disrupt or destruct the endometrium. This may cause amenorrhea. So no matter how many hormones are secreted, but the uterus will not respond to those hormones because the endometrium is disrupted. Then there may be other causes of, say, adrenal causes, which may cause amenorrhea. And tumors of the adrenals which may secrete androgens. Then there is adult onset adrenal hyperplasia or late onset congenital adrenal hyperplasia, which may be a cause of secondary amenorrhea, but more often it presents with delayed cycles in a PCOS-like picture. Then there may be thyroid affections also, which may cause amenorrhea. So how to differentiate and reach to a diagnosis in so many causes of secondary amenorrhea? So the most important is the history taking. Then we have to follow these steps. First, take a detailed history of every woman coming with the complaint of secondary amenorrhea. Then we do examination, then targeted investigations, and then we can manage these women. Then important is also the role of family history. So we should know the physiology of the family, that what is the age of menarche and menstrual pattern or the age of menopause in the family members like the mother or the sisters, because probably there are some patients who may have earlier menopause or they may have premature ovarian insufficiency or POF. Then there may be history of certain chronic disorders which are sometimes diagnosed only when the patient presents with POI. So these are the histories that we should always take, and a detailed history of tuberculosis, any contact history should also be taken. Then what are the clues from the history that we can get? Nausea, vomiting, if the patient is coming, then definitely we should rule out pregnancy. But if patient is also having signs of hyperandrogenism, that is hirsutism, acne, then male pattern baldness, facial hirsutism, then we know if amenorrhea with all these signs, we should rule out, we should diagnose PCOS and we should, think of PCOS. But if this same hyperandrogenism is severe enough or is causing virilization. Now, what is virilization? There is a difference between hyperandrogenism, hirsutism, and virilization. So, all these are signs of hyperandrogenism. It shows that the androgens are high in the body of the woman. Hirsutism is increase in facial hair, which is coarse, long, hard, or bird, mustache or bird-like hair which are present on the face of the woman or the body of the woman. This is known as increased hair growth, male pattern hair growth. This is known as hirsutism. But what is virilization? Virilization, in addition to hirsutism, there is androgenization of various other organs of the body. That is deepening of the voice. So this deepening of the voice under the effect of androgens may cause, this is also known as virilization. So which will give, the patient will come and say, Doctor, my voice has become a bhari, heavy ho gayi hai, and it has changed over a period of time. Then this gives us a clue that probably there is some androgens which has increased in our body. Clitoromegaly, if the size of the clitoris has increased, or severe hirsutism. And one more thing, that the patients may come and specifically tell that the size of my breast has, it appears that it has decreased. So breast is atrophy. So if there is new onset virilization symptoms in the signs in the women, it suggests that the androgen level is high and probably there may be some androgen secreting tumor, which is also causing amenorrhea. So CAH or androgen secretory tumor. Then the presence of galactorrhea, visual symptoms, headaches, again point towards CNS pathology. Then, which we have discussed, excessive weight loss, stress, athlete. If the then it also hints towards functional hypothalamic causes or hypogonadism, because these are the patients, everything is okay. If they this stress is reduced or the eating habits are improved, the women will have normal menses. Then any obstetric event, very important to take the history of obstetric events in these women, because the patient may give a history of severe PPH or anything suggestive of pituitary apoplexy or Sheehan syndrome. So it is important to take these histories. And even, initially the GTN may present as secondary amenorrhea, but then the pregnancy test will be positive. So it's a different story. Then history of any drug, CT, RT should be taken. And then any symptoms of menopause, that is vaginal dryness, hot flashes, they all point towards gonadal insufficiency. So this will give us a clue that the patient may have ovarian failure. So these are the clues we should take whenever we are taking a detailed history of for secondary amenorrhea. Then now comes the examination. So definitely height, weight, BMI, they are all going to hint towards various factors like hypothalamic causes of amenorrhea or PCOS or obesity, because obesity per se may cause anovulation and there may be secondary amenorrhea. Then there may be examination of skin color, texture, which may give rise to other endocrinopathies like Cushing syndromes or hair pattern, that is hirsutism and androgenization. Then I've already discussed we should look for signs of virilization, examination of thyroid, and examination of breasts should also be done, because if we do that, the patients may give a hint that yes, they have decreased in size or have become, asymmetrical. Then if the patient is having any Turner stigma are usually present in typical Turner syndrome. But if the patient is presenting with short stature or one or two Turners, which may be present in patients with Turner mosaic. So depending upon the percentage of normal and abnormal cell lines, the patient may present with menarche, subfertility, and then POI. So this should also be looked into. So how do we do breast examination? Breast examination should be done very systematically, gentle compression, beginning at the base and moving towards the nipple. So all these things will give us it will also help in examining the breast and also know the Tanner stage, whether it is decreased or is the same. And also we should then look for any nipple secretions, which may give a hint towards galactorrhea or prolactin secreting tumors or hyperprolactinemia. So any patient in secondary amenorrhea, breast should always be examined. Now investigation. So once we have taken a history, clues and examination, then we should do targeted investigations. So pregnancy should be ruled out. And if you think we are not able to do it, then get a UPT test done. Otherwise, get a baseline CBC. If we are thinking that everything else appears normal, but there may be some chronic disorders, severe anemia or anything, if we are suspecting, then we should do the tests. Otherwise, we can do FSH-LH. So any patient presenting with secondary amenorrhea, we should first do gonadotropin testing. So gonadotropins will give us a hint whether the problem is at a higher level of HPO axis or at the lower level of HPO axis or at the level of ovarian or at the level of ovaries. So if the FSH is high, gonadotropin levels are higher than normal, it suggests that hypothalamus and pituitary are functioning well. They are secreting gonadotropins, but the ovary is not responding to those gonadotropins, suggesting that there may be ovarian failure. If the gonadotropins are low, this suggests that the hypothalamus or pituitary is not working properly and the problem is at the upper compartment. So we should evaluate those causes, and then they are known as hypogonadotropic hypogonadism. Now, if the FSH-LH are within normal range, then H, P and O, all three are functioning properly and the end organ, that is the uterus, is not responding. So getting gonadotropin level will give us a very important clues that where the problem may lie. Another is that if everything is high, normal, then we should get other hormones done. So if there is hyperandrogenism clinically, then along with FSH, we can get the testosterone done. 17-OHP to rule out late onset congenital adrenal hyperplasia, and dihydroepiandrosterone sulfate to know the source of androgen. So if DHEAS is high, it suggests that the source of androgen is adrenal glands, not the ovarian gland. Then we do TSH, hypothyroidism, hyperthyroidism. They may cause amenorrhea. Then prolactin level. Prolactin level will suggest whether there is hyperprolactinemia, and if the levels are very high, more than 2 standard deviations, then we should look for adenomas. The adenomas may be microadenoma or macroadenoma. Then we should, if prolactin is very high, more than 2 standard deviation, then we call that the prolactin is increased, because prolactin is a very sensitive hormone. Even a slightest amount of stress may cause increase in prolactin levels. So if we are doing all the work in the home, sending children to school, work, tiffin to husband, and then we say, okay, now let me go and give the test for prolactin, then the prolactin may be raised. And if the prolactin is not more than 2 standard deviation, then we should consider it as a physiological increase in the prolactin. And if we should repeat it again, giving instructions that the patient should avoid, sex, patient should avoid warm bath, and should give it first thing in the morning after waking up, before she is busy in her day-to-day activities. So prolactin is a very sensitive hormone. Now, karyotype. What is the role of karyotype? There are certain conditions of hypergonadotropic hypogonadism where we should get the karyotype done. Then ultrasounds should always be done to find out about tumors, or MRI brain can be done to complete the list and to find out the exact cause. Now, what is the indication of karyotype testing? Not all patients with amenorrhea should undergo karyotype testing, because it is not going to give us any additional information. We should understand why we are doing karyotype. We are doing karyotype to find out about any chromosomal anomalies the patient may have. So if everything is fine, she has been menstruating normally, and she may have children also, successful pregnancy outcomes also. And if then she is having secondary, it is very less likely that the patient may have any chromosomal anomalies. If the patient is having hypergonadotropic hypogonadism, suggestive of ovarian failure. So whenever there is gonadal failure, in that situation, we should always get a karyotype done. So in all patients under age 30 with hypergonadotropic hypogonadism, we should test for karyotype. And even after 30 years, if we have a family history of early menopause, POI, short stature, we are suspecting some problem, then we should go for karyotype testing. Otherwise, we don't need to do. So it is the hypergonadotropic hypogonadism is there, then we should go for karyotype testing. Even hypogonadotropic hypogonadism does not require karyotype testing. Then now, how to evaluate, and the algorithm, how we should go and place which test where. So we know that secondary amenorrhea is because of anovulation due to any causes. Most of the causes are they may have multiple problems, but the end is that they are causing anovulation. So we have to look for those causes, or there is end organ damage, which is a fraction of causes which may cause end organ damage. So now, what are the different causes of anovulation? We know that there is a WHO classification of anovulation. This is just based on the HPO compartment. So WHO type 1 is known as hypogonadotropic hypoestrogenism. That is, the FSH is decreased, the E2 is decreased. They both are decreased, which suggests that the problem is in the hypothalamus. That is the compartment 1, WHO compartment 1. Then WHO compartment 2, which is the most common cause, and this is known as eugonadotropic. That is, FSH will be in the normal range and E2 will also be in the normal range. Most common cause of secondary amenorrhea, that is PCOS. So we know everything about PCOS. I am not going to go into detail, because otherwise we will not be able to discuss other causes of secondary amenorrhea. Then there is hypergonadotropic hypoestrogenism type 3. Here the FSH levels is high, but E2 is low. So this is POI, that is at the gonadal level. And these constitute about 10 to 20% causes of anovulation or secondary amenorrhea. And the fourth is others. And the others most common is hyperprolactinemia, where the prolactin secretion is increased, which causes anovulation which causes secondary amenorrhea, and they constitute about 5 to 10% of causes of secondary amenorrhea. So PCOS, I think I will not discuss, but if any questions, I can take it. So now let's go to the our algorithm that how we may go. So first, if we are not sure of, let's do an UPT test and rule out pregnancy. Then once the pregnancy is ruled out, then we get the hormone analysis done. Now, when to do this hormone analysis? Usually we do hormone analysis on day 2 to day 3 of the menstrual cycle. So if the patient has recently had a withdrawal bleeding or say delayed cycles, then we can get it done on day 2 to day 3, which is a very common scenario in PCOS. But if the patient is having long spells of amenorrhea, then we can get these tests as a baseline without giving any hormone stimulation, without even subjecting to, this hormones for menses, but we should get a baseline hormone profile done. And in the side, we can also order for USG scan of the ovaries and the uterus. So if the LH-FSH is high, which we call as hypergonadotropic hypogonadism, then we should go for karyotype also. But if the LH and FSH are low, that is less than 3 to 4 MIU per L. Because if levels are less than 3 to 4, then only we label them as low LH or FSH. Then they are known as functional amenorrhea or due to any chronic illnesses which is causing problem in the hypothalamus and pituitary. They may be infiltrative disease. There may be damage to the pituitary because of chronic infections also or any chronic illnesses. If the LH and FSH are normal, then if there is a history of infection, tuberculosis, DNC, then there may be Asherman syndrome or hyperandrogenism is suggestive of PCO type of picture, or 17OH is to be done, and which may give a clue to COH. If the testosterone level which we get done is very high, more than 200 nanogram per deciliter, then we should go for an ultrasound and rule out androgen secreting tumors. The tumor may be a very small tumor located either in the ovary or in the adrenal cortex, which may be secreting testosterone enough to cause amenorrhea and hyperandrogenism. Then PCOS we can always say because it is a eugonadotropic. So if everything is fine and their Rotterdam criteria are met, then we can diagnose them as PCOS. Now the normal LH-FSH, how to evaluate these cases further? We have progesterone and estrogen progesterone challenge test. So if we see that the patient's hormones are within normal limit, then we have to find out that where is the problem. In that case, we can first give her a progesterone challenge. And progesterone challenge is giving oral progesterone for 7 to 10 days to that woman. And if there is bleeding, then it suggests that the patient's lacking was progesterone. That is, there was long spells of anovulation. Estrogen priming of the uterus has already been done. And progesterone was lacking, that is anovulation was there. So progesterone challenge test positive suggests anovulation. So it may be PCOS or the patient other causes like prolactin also we should look for, but most common causes, if a secondary amenorrhea patient bleeds on progesterone challenge test, then the most common cause is PCOS. Now if there is no bleeding on giving progesterone, in that case, probably the estrogen priming of the uterus has not been done. That is deficiency of estrogen. So here what we give, to confirm this, we give combined estrogen progesterone test. So which we can give in the form of OCP also, or we can give Proginova followed by progesterone, that is Meprate. So estrogen and progesterone followed by progesterone can be given for 21 days. If bleeding happens, This suggests that the end organ is perfectly okay, the uterus is there, and the cause may be either, gonadal failure, where they are not able to secrete the estrogen. So there is problem in the hypoestrogenism. And if the bleeding does not occur, then there is damage to the end organ. So there may be infection or trauma to the endometrium. So there is no endometrium which will respond to the cyclical estrogen and progesterone. So the bleeding is not happening. So this progesterone, correct use of progesterone challenge test followed by estrogen progesterone challenge test will give us good clues that what type of anovulation or what is problem is at what level. So we should always give a progesterone challenge test first, not estrogen progesterone challenge test, because if once we give estrogen progesterone challenge test, then we will not know whether the estrogen was already there in the body or not. So this is the algorithm or the how to diagnose or reach to a diagnosis in patients with secondary amenorrhea. Now I'll touch very little about certain types of diseases which are common to our gynae practice. So the most common cause of secondary amenorrhea is Asherman syndrome, that is end organ failure, and this is also of clinical relevance to us because most of these women, they come to us with infertility and we have to treat these women. So here it is a type of eugonadotropic eugonadism. So the HPOX is functioning very well. So the hormones will all be within normal limits. It is the negative estrogen progesterone challenge test which will give us a clue that this is an Asherman syndrome. We know that there are various causes, various curettage for pregnancy complications, or after hysteroscopic operative hysteroscopic surgeries like myomectomy, polypectomy, or septal resection if it is not done in a proper way. Otherwise, it does not cause any problem. Or infections, sepsis, most common being genital tuberculosis in our country. So they present with hypomenorrhea and infertility. There is destruction of the bacillus layer, so there is no menstruation. So it can be diagnosed with HSG. Hysteroscopy is the gold standard for diagnosis, as well as operative hysteroscopy is for treatment of intrauterine adhesions. So another important is premature ovarian insufficiency. This is also very commonly present in our gynae OPD. So amenorrhea arising before the age of 40 years is known as premature ovarian insufficiency. It may be, because of some disease, or it may be genetic also. So this is hypergonadotropic hypogonadism. That is, FSH will be more than 25 IU per liter, and it should be confirmed on 2 occasions 4 weeks apart. Now, since it is before the age of 40 and hypergonadotropic hypogonadism, we can get a karyotype done to diagnose whether the patient is suffering from having any chromosomal anomalies or any cell lines that can have chromosomal anomalies. So the prevalence is around 1%, and the patients will present with typical symptoms of estrogen deficiency, that is hot flushes, loss of libido, weakness, and vaginal dryness. They may also have palpitations because young patients with the estrogen deficiency, along with the typical night sweats and hot flushes, palpitations is a very common symptom in these women, which gives us a clue to hypoestrogenism. So they may have now these patients with premature ovarian patients may have intermittent ovulation also, intermittent ovarian function that can lead to ovulation, and 5 to 10% may conceive or deliver. So depending upon whether the patient is having fertility issues or the patient is not having fertility issue, we need to treat. So if the patient is not having any fertility issues, then these patients should be started on hormone therapy till the age of the natural menopause. All these women of premature ovarian insufficiency should be started on hormone replacement or menopause hormone therapy. There may be various causes of even genetic causes also, so which we usually should try to identify because they may run into families. Otherwise, the treatment is same. If pregnancy is wanted, then we may go for donor ovum, or we may go for menopause hormonal therapy depending upon the patient's symptoms. So how much estrogen? This again is another talk altogether, but for all practical purposes, because these women have an intact uterus inside, so we go for estrogen plus progesterone therapy. Then also weight-bearing exercises, calcium and vitamin D should be there. Bone mineral density should be done to these young women to know the baseline bone health of these women. Then comes gonadectomy. Usually it is not required because most very small percentage of patients with POI may have a Y line. So if they have a detectable Y chromosomal line, no matter how small the percentage is, because 15 to 10% of Y lines will have cell lines will have a Y chromosomes. So gonadectomy should be offered to these women. Then another is Sheehan syndrome, because we deal with obstetric cases. So any of our patients, if having pituitary apoplexy because of severe hemorrhage, then these patients will present with secondary amenorrhea, and most importantly, the lactation failure. Because after pregnancy, amenorrhea may be there, but if it is a lactation failure, then it is pathognomonic of pituitary apoplexy. It is caused by acute infarction and necrosis of the pituitary gland resulting from severe bleeding and hypovolemic hypotension. So these women, then they are placed on, after the confirming the diagnosis, they are placed on hormone replacement. Not only estrogen, progesterone, but the other hormones which are secreted from the pituitary should also be evaluated, like thyroid, which is most common deficiency, and also the cortisol should also be measured, and if required, it has to be replaced. Congenital adrenal hyperplasia. Congenital adrenal hyperplasia usually presents around menarche, but if it is a late onset congenital adrenal hyperplasia, then they present sometimes with secondary amenorrhea, because congenital adrenal hyperplasia, these patients, they enter into an accelerated puberty, and then they may have one or two menses, but then they may start having delayed menses or secondary amenorrhea. So these are the women, they should be diagnosed with 17 OHP, and usually they are treated with like PCOS with glucocorticoid replacement in addition to a treatment for fertility that we are giving for these women. So once they are on glucocorticoid replacement, they may have their regular menses as well. But if still they are having delayed, then we may put them on OCPs as well. Now, these are, we will be discussing some of the hypothalamic causes. Hypothalamic causes of amenorrhea, the most common is the functional hypogonadism. They may be primary, they may be secondary. If they are secondary to any disorders like chronic diseases, tumors, CT, RT, or brain trauma, then they are treated according to the problems these patients are facing. But we will be discussing here something about functional hypothalamic amenorrhea. What triggers functional hypothalamic amenorrhea? It is the psychological stress, disordered eating, excessive weight loss. This weight loss is not only excessive, but is a sharp decline in the weight because the patient has literally stopped eating. So there is a calorie deficit in these patients. Excessive exercise, which we have told you that the athlete syndrome is there. So they have to maintain their weight in the bracket what they have chosen to play. What it causes, all this psychological stress causes increase in corticotropic releasing hormone in response to the stress. Now this causes decrease in the pulsatility of the GnRH. We know it is very important that around for the Pituitary to respond, the GnRH should be secreted in a pulsatile manner with a fixed amplitude and frequency. If this amplitude is decreased, then the GnRH is secreted in a waveform type of distribution or continuously. So this causes functional hypothalamic amenorrhea and the pituitaries are not stimulated. So FHA is a diagnosis of exclusion as it is a non-organic cause of amenorrhea. So before diagnosing any patient with functional hypothalamic amenorrhea, we should rule out all other organic causes of hypothalamic amenorrhea, then only label these women as FHA. Now we should talk of female athlete triad. Again, the same. They have to keep their, weight in a fixed strata. So these women, they have less than 30 kilocalories per kg of free fat mass. So their critical mass is so low that these patients have gonadotropin release is not initiated. That is the pulsatile release of gonadotropin. This pulsatile fashion vanishes. So there is anovulation and oligomenorrhea that leads to amenorrhea. There is an increased risk of stress fractures in these women mostly because of the high strength of physical activity that they undergo. So to conclude my talk on this, I would like to give few take-home messages, and the most important is that whenever a woman comes, we should start from history. Take a detailed history. After examination, we should get the hormone profile done. This hormone profile will let us know whether it is hypergonadotropic hypogonadism leading to amenorrhea or it is hypogonadotropic hypogonadism. That is, if it is hypergonadotropic, that is, gonads are not responding to the high levels of FSH and LH, then go for karyotype. But if it is hypogonadotropic, we know that the problem is in the CNS. Then the role of progesterone and estrogen-progesterone challenge tests. So we should utilize these tests to differentiate between the various causes of secondary amenorrhea. Counseling is very important because if these patients also have fertility issues, then this is a very devastating news to many of these women if they are suffering from POI or any non-treatable causes of secondary amenorrhea. So the counseling from the point of diagnosis forms the spine of the management. Psychological counseling should always be offered and it should be part of the multidisciplinary team. Hormone replacement should always be given to these young patients of POI, which is very important for their bone health, and always discuss the fertility issues of these women and treat accordingly. Thank you very much for your patient hearing.
Thank you so much, Garima ma'am. It was very elaborate talk and very useful, especially regarding when to do all the tests. I mean, targeted approach towards the test and management. And now I would like to, if Kiranmai ma'am has joined, I would like to request ma'am to give some comment. Dr. Manshi?
Kanchan Kiranmai has not joined. She's stuck somewhere.
Okay, sir. Then I will request Dr. Manshi.
Garima, it was an excellent presentation. This is what we actually wanted from you. So when we were thinking of having a speaker, then Vaishali was insistent that we should have Dr. Garima as a speaker because all of us have heard you in the gynae endocrine conferences earlier. So thank you very much for being part of today's program.
Thank you, sir.
An
Thank
excellent
you so
lecture.
much.
Vaishali, your comments, please.
Thank you so much. As Sir said, I totally agree that this was an excellent presentation, and we always thought that you would be the perfect person to give this deliberation, and you actually proved that you are the right choice, and you covered it so well for the students, for the practicing consultants, for everybody. It is very useful, and thank you for simplifying the topic so well. And I thank Parag sir for giving us this opportunity to have this program with FOGSI Endocrine Committee, and ICOG is the main person or main contributor, and sir's blessing with which we are conducting this program. and it is very well appreciated. I thank the chairpersons as well, and thank you once
Thank you
again,
so much
Dr.
for
Garima.
inviting me and giving me this opportunity to be part of this prestigious ICOG CMEs. And I hope I tried to summarize everything in this much time, and I think I did a reasonably well job.
Yes.
It was
Yes.
very informative talk, very useful and very practical for everyone.
Yes.
Postgraduate,
Yes.
general, the private practitioner, everyone. Ma'am. Thank you so
Yes,
much.
ma'am. Thank you, ma'am.
Thank you,
So,
Kanchan madam, for gracing this particular topic, and thank you for your comments. Thank you so
thank
much.
you. Now over to Dr. Mansi.
Thank you, ma'am. It was really an insightful and detailed talk, and actually in a simplified manner, which all of us could understand. And I would also like to thank our chairpersons for joining us today. We move on to the next part, which is the quiz. So I would request everyone to please stay with us and join us for the quiz as well. Can I request Khushi to share the link for the quiz in the chat box, please,
Yes,
as well as
ma'am.
on the screen?
Yes, ma'am. Let me share first the link.
We have a small quiz which is related to today's topic, which is secondary amenorrhea. So I will request everyone to join us for the quiz.
I hope my screen is visible to you, right?
Yeah.
Yeah. So,
You can
dear
join.
participants, you can join by scanning this QR code as well.
Yeah. And share the link also in the chat box, Khushi. Yeah, we have shared the link as well in the chat box. If anybody has any difficulty in joining the link or not able to join through the QR code, you can please let me know. We will be starting in 2 minutes more. I think we have 5 or 10 people who have joined us through the link. 10 players are ready. We have 5 rounds. The first round is, as usual, each round has 5 questions and the total scores will be available. After each round, we will be dealing with the scoreboard. Let's start, Khushi. We will be starting with the first round and the link is available. You can join anytime.
We can start right now.
Yes. Let's start. So the first question for the first round is, a 26-year-old woman with secondary amenorrhea and infertility undergoes the HSG. The findings are shown in the pic, which is the gold standard investigation for confirmation and treatment, whether it is hysteroscopy, whether it is saline infusion sonography, whether it is MRI pelvis, or whether it is endometrial biopsy. You can see the picture. What is that picture indicating? I think ma'am has shown it in her slide as well. You have to identify the correct answer. Time is up. Yeah, 10 of you are correct. The picture is of Asherman's. The correct diagnosis and confirmation. The correct answer is hysteroscopy. Can we have the next question, please? A 26-year-old woman developed failure of lactation followed by secondary amenorrhea after massive PPH. The MRI demonstrate empty sella. What is the underlying pathology? Whether it is ischemic necrosis of the pituitary, whether it is prolactinoma, whether it is tubercular meningitis, or whether it is hypothalamic tumor. This also we were just talking about. So the underlying pathology you have to identify. Yes. Only two wrong answer. The correct answer is ischemic necrosis of the pituitary. Sheehan syndrome. Next question, please. This investigation is primarily used to assess complication associated with which cause of secondary amenorrhea, whether it is PCOS, whether it is hyperprolactinemia, whether it is hypothalamic dysfunction, or whether it is Asherman syndrome. There is a picture which is shown of some investigation. This investigation is used to assess complications which are associated with which form of secondary amenorrhea. Yes, 12 of you are correct. The picture is of a DEXA scan, which we use it to assess osteoporosis and other bone mineral density. The correct answer is hypothalamic dysfunction. So 12 of you are correct. Can we have the next question, please? In women with the condition shown, secondary amenorrhea most commonly occurs due to excess growth hormone directly suppressing ovaries or co-secretion of prolactin by pituitary adenoma, decrease ACTH secretion, or increase adrenal androgens. We have a woman, and the other picture is just to show the features which are seen in that condition. You have to tell me the correct. Okay. See this question. The correct answer is acromegaly. So because of that, a lot of you must have thought that excess growth hormone directly suppressing ovaries would be the answer. So that is not the correct answer. In acromegaly, though the growth hormone is there in excess quantity, it does not directly suppress ovary, and that is not the cause of secondary amenorrhea. It can be either of the other causes, like either the adverse effect on the GnRH pulsatility of those hormones, or co-secretion of prolactin by the pituitary adenoma, or due to the pituitary stalk compression. So any of those can be the correct answer, but excess growth hormone directly suppressing the ovaries is not the mechanism of secondary amenorrhea in acromegaly. So the correct answer is B. Can we have the next question, please? Which endometrial risk is increased in the patient with pathology shown in PIC when the secondary amenorrhea persists, whether it is endometrial cancer, whether it is endometrial atrophy, whether it is endometritis, or whether it is Asherman syndrome? There is a picture which is showing one of the, which is characteristic of a disease. So what is the endometrial pathology which is seen when you have this disease and secondary amenorrhea persists? Yes, 16 of you are correct. It is endometrial cancer. The picture is of PCOS. Very simple, clear-cut answer. Can we have the score after this round, please? Okay, so Sukriti Singh is leading with Yukti, Raga, and Sonalika after that. We move on to the next round. Resistance ovary syndrome differs from premature ovarian insufficiency by high FSH and absent follicles on histology, high FSH but presence of primordial follicles in biopsy, low estrogen and low gonadotropins, or none of the above. You have to tell what is the difference between both. Very simple, clear-cut answer. Yeah, 12 of you are correct. The correct answer is high FSH, but the presence of primordial follicles in the biopsy, which are resistance to the gonadotropins. Can we have the next question, please? Which of the following is a diagnostic criteria for PCOS? I think it's very, very simple. Oligoanovulation, clinical or biochemical hyperandrogenism, insulin resistance, or polycystic ovarian USG. I think it's the most simplest question in the whole quiz. You can take it as a Rotterdam criteria for PCOS. Yeah, we have 14 correct answer. Insulin resistance is not a diagnostic criteria, though it is present in almost all of the cases, especially obese, but it is not known as the diagnostic criteria. Can we have the next question, please? In hypothalamic amenorrhea, which neuropeptide is most directly implicated in decreased GnRH pulsatility, whether it is kisspeptin, whether it is neuropeptide Y, whether it is CRH, or whether it is leptin? Okay, 6 of you are correct. The kisspeptin is directly implicated with the hypothalamic amenorrhea. So the correct answer is kisspeptin. Can we have the next question, please? Which genetic mutation is most strongly linked with familial POI, whether it is BRCA1, whether it is Fragile X pre-mutation, whether it is CFTR mutation or MEN1 mutation? These are all straightforward questions. Yeah, 17, I think only two wrong answers. 17 of you are correct. It is Fragile X pre-mutation, which is associated most strongly linked with familial POI. Can we have the next question, please? Which ovarian cells are most sensitive to chemotherapy, alkylating agents, induced damage? Whether it is granulosa cell of the primordial follicles, whether it is theca internal cells, whether it is corpus luteal cells, or whether it is ovarian surface epithelium. Most of these questions are directly taken from either Novak or Sperov. Yes, all of you are correct. The correct answer is A, granulosa cells of the primordial follicles. With this, we are done with the 2 rounds and the scoreboard remains same. With Yukti has the longest streak of correct answers, almost 6 answers she has answered correctly. So very nice, Yukti, keep it up. Can we have the next round, please? We move on to the round 3 and the first question for this round is: a patient with PCOS and secondary amenorrhea undergoes oral glucose tolerance test. The result most likely shows increased insulin sensitivity, increased fasting insulin, normal insulin dynamics, or hypoglycemia after glucose load. Uh, 11 of you are correct. The correct answer is increased fasting insulin. There is hyperinsulinemia, leading to compensatory insulin increase after fasting and after the insulin load. Can we have the second question, please? A 20-year-old sexually active woman has had no vaginal bleeding for 6 months. She is obese, slightly hypertensive, has excessive hair growth on chin and galactorrhea. Which diagnosis should you consider first? Whether it is hypothyroidism, whether it is androgen secreting tumor, whether it is pituitary adenoma, or whether it is pregnancy. Okay. The correct answer is D. Anytime a sexually active patient comes to you with amenorrhea, the first diagnosis you have to consider without fail is pregnancy. So the correct answer is D, pregnancy. Okay, can we move on to the next question, please? A 30-year-old woman with secondary amenorrhea has the following: progesterone withdrawal test negative, estrogen plus progesterone challenge test negative. What is the most likely cause? Hypothalamic dysfunction, ovarian failure, outflow obstruction, or Asherman's or pituitary failure. I think we have discussed this so much in the presentation. Right now, it's very clear-cut answer. Yes, 11 of you are correct. Estrogen progesterone challenge test negative, end organ damage, uterine cause, Asherman's. The correct answer is C. Can we have the next question, please? A woman with secondary amenorrhea has low FSH, LH, low estradiol, and low leptin. What is the most likely cause? Whether it is functional hypothalamic amenorrhea, whether it is PCOS, whether it is Turner syndrome, whether it is androgen secreting tumor. She has low FSH, low LH, low estradiol, and low leptin. There is a hint with low leptin. Yes, 17 of you, almost all of you are correct. Functional hypothalamic amenorrhea is the correct answer. Can we have the next question, please? Which range of CGG repeats in the FMR1 gene is associated with increased risk of POI? It is a very theoretical question. Whether it is less than 45, whether it is 55 to 200, more than 200, or between 200 to 400. Directly taken from the theory book. Let's see. Okay, 8 of you are correct. The correct answer is the CGG repeats between 55 to 200 are associated with almost 20 to 25% risk of POI. Less than 45 is almost normal ovarian function or normal alleles. If it's more than 200, it directly leads to hypermethylation, total mutation, as well as Fragile X syndrome, which is not directly associated with POI. So the correct answer is B, which is 55 to 200. Can we have the score after this round, please? Okay, so Yukti has a longest streak with 7 correct answers, followed by Sukruti, Sonalika, Ragha. So the leaderboard almost remains the same. We move on to the next round, which is round 4. A 24-year-old woman with secondary amenorrhea has labs of TSH increase, T4 decrease, prolactin increase, FSH and LH are normal. What is the mechanism of amenorrhea? Whether it is direct ovarian failure, endometrial atrophy, whether it is TRH mediated hyperprolactinemia leading to GnRH suppression, or pituitary infarction. If you look at the question, almost the answer is given there. Yeah, all of you are correct. The correct answer is C. Can we have the next question, please? Among the chemotherapeutic agents, the one most commonly implicated in causing the premature ovarian insufficiency is cisplatin, cyclophosphamide, methotrexate, or vincristine. Which is most commonly implicated in causing POI among all of these? Okay, 12 of you are correct. The alkylating agents are more commonly associated with causing POI. Cyclophosphamide is the correct answer. Can we have the next question? Which of the following is not typically seen in functional hypothalamic amenorrhea? Low GnRH pulsatility, low FSH-LH, low estradiol, or elevated AMH? Almost all of you are correct. The correct answer is elevated AMH. AMH is either normal or slightly on the almost normal or lower side, but never elevated. So the correct answer is D. Can we have the next question, please? In adolescent girls with exercise-induced amenorrhea, why do weight-bearing or resistance exercises fail to fully prevent osteoporosis? Whether it is due to the mechanical loading is ineffective in adolescents, or estrogen is required for optimal bone mineralization, or only calcium deficiency causes bone loss, or growth hormone suppression is the major mechanism. We are talking about adolescent girls. Okay, 12 of you are correct because estrogen is required for optimal bone mineralization. That is the correct answer. Can we have the next question, please? Pregnancy in women with untreated macroprolactinemia carries the highest risk of whether it is preterm labor, whether it is tumor enlargement, gestational diabetes, or postpartum hemorrhage. Untreated macroprolactinemia we are talking about. Yes, 8 of you are correct. The correct answer is tumor enlargement due to excessive estrogen. The chances of increase in the size of the tumor are very high. So the correct answer is B. We move on to the leaderboard score. It remains slightly different with Ankita getting to the 4th position and Yukti continuing her winning streak. We move on to the last and final round. The first question for this round is, which is the preferred long-term management of POI in a young woman without contraindications, whether it is calcium plus vitamin D daily, whether it is bisphosphonate, whether it is HRT until the average age of menopause, or no treatment is required? It is almost very straightforward, simple question. Yes, almost all of you are correct. The correct answer is C. The next question, please. A 25-year-old woman presents with secondary amenorrhea, galactorrhea, and headaches. Prolactin is 180 nanogram per ml. MRI pituitary shows a 9 lesion. Best initial treatment would be whether it would be cabergoline, whether it would be bromocriptine, transsphenoidal surgery, or radiotherapy. Almost 11 of you are correct. Cabergoline is a selective dopamine agonist, so it is a better choice among all of those. Can we have the next question? Which of the following is not a long-term consequence of cyclophosphamide-induced POI? Secondary amenorrhea, infertility, osteoporosis, or increased risk of endometrial carcinoma? Not a long-term consequence. Yeah, 13 of you are correct. Endometrial CA, which is normally associated with unopposed estrogen action, but here we have hypoestrogenism. So the correct answer is D. Can we have the next question, please? In which autoimmune polyglandular syndrome APS do women have the highest risk of developing POI, whether it is APS type 1, type 2, type 3, or none? POI is not associated with APS. So you have to select one of these answers. Okay, Okay. Again, the correct answer is type 1. There may be some confusion, but directly taken from Sperov, the type 1 is associated 50 to 60% with POI due to the AIR mutation. So the correct answer is type 1. Though the incidence is lesser in the clinical practice, so that may be overall. Okay, and we move on to the next question. Which of the following statements about macroprolactinoma is true? Surgery is the first line treatment. Most require radiotherapy. Dopamine agonists are highly effective in restoring cycles, and they rarely cause menstrual disturbances. Okay, almost all of you are correct. The dopamine agonist, we have the winner. Yukti is on the first position, followed by Sukriti, Sonalika, Ankita, and Shabnaz. So congratulations to all of the winners. And thank you for participating in the quiz. And I would also like to...
Manatik, very well done. I was listening to the entire quiz while I was traveling. Good job. Now you've become a pro in conducting quiz. I've seen you over the last 5 years conducting quizzes, so good job. And congratulations to all the participants, and of course, Yukti, who's the winner today. I think I'll just quickly propose a vote of thanks and we conclude today's session. First and foremost, thank you to our speaker today, Dr. Garima Kachava, for a brilliant presentation, Dr. Kanchan Prasad, who chaired the session, and of course, thank you, Mansi, for conducting the quiz flawlessly, and of course, all the participants were here. So tomorrow onwards, that is 17th, 18th, and 19th, the ICOG will be having a Urogyn gynecology certificate course. It is going to be a 3-day course between 4 p.m. to 7 p.m. Of course, at the end of the day, there would be a MCQ which have to be attempted. So if you attend all 3 days, attempt the MCQs and secure more than 50% marks, you are eligible to receive a certificate from the Indian College of OBGYN. So I hope to see you all there tomorrow and have a good evening. Thank you all.
Thank you, sir. Thank you.